Yeah, so we're going to bring this show to order here soon. We have a few more stragglers from out yonder. All right. How are we doing out there? Are we mostly? Yeah. We're mostly here? Yeah. Good. Welcome, everyone. Great food, by the way, huh? This is nice. I like this. I want to say, even before I get started, I want to thank our Center for Vaccine Equity team and our Office of the President team and everyone else who's been involved in helping put this together and make it happen. Great job. Thank you all. So let's just give them a round of applause. They're all working the evening, but I want to thank you guys, so thanks. So welcome, everyone, including our viewers on our live webcast to tonight's symposium, Preparing for the Next Pandemic, Lessons Learned from the 2017-2018 Flu Season. I'm Dave Ross. I'm the President and CEO of the Task Force for Global Health. Thank you all for being here. Thank you for coming out. And thanks to all of those you listening out in cyberspace. You know, last year's flu season was one of the deadliest in years, and it exposed our vulnerability. We are really, as a nation, very vulnerable, and as a world, highly vulnerable. So tonight you're going to hear from some of the world's leading experts about what happened, both here in Atlanta and globally. And we're going to talk about how we can better prepare for the next global outbreak. Let me say a word too about the task force. I imagine most of you in the room tonight know something about us, but here at the task force, we tackle some of the toughest problems facing public health, both here in the United States and throughout the world. We focus on disease control, elimination, and when possible, eradication. We are a home for major partnerships, I think 8 partnerships and coalitions that address elimination of diseases around the world. And the Partnership for Influenza Vaccine Introduction, PIVI, is one of those really important partnerships. So you're going to learn more about PIVI tonight. This week, we also had really the distinct honor of meeting partners from CDC and the World Health Organization, who selected the strain for the flu vaccine that will be used in next year's vaccine in the Southern Hemisphere. I have to say, I was so way cool to have in this room global experts assembled, spending the week doing the formulation. We here at the task force are honored to have been able to offer the space to make that happen. Honored that Atlanta is the kind of hub for global health in the world, very unique and largely driven by the existence of CDC. But this is a special place for global health. It's an exciting time for us here at the task force. As some of you know, 2 years ago, we were honored to win the Hilton Humanitarian Prize. That's a really good thing. It happened to come with a great big check. But it was an extraordinary honor, and it was given to us for our work in alleviating suffering throughout the world. Over the last few years, we've experienced exceptional growth, and I would forecast that that kind of programmatic growth will continue. And so it speaks to a strong demand for our services. Recently, we've added new programs, one in leprosy elimination, another in medical surplus recovery, and we've started a new focus in global health ethics. And we are now anticipating soon a launch of a new initiative in viral hepatitis elimination. So we're doing a lot. If I have my way, we will keep doing more. I hope that you all have the opportunity to look around at our new facility. You're getting to see conference space here. We're really proud of it. We're happy to have been able to acquire this building, and we want to thank and acknowledge the Woodruff Foundation, the Hilton Foundation, and the Petulak Foundation here in Atlanta for their support in helping make this possible, as well as leaders from the DeKalb County government and Board of the Commissioners of DeKalb County who agreed to sell us this building. So all of these are wonderful partners. I would let you know that when this building is fully renovated, we envision developing a new center for global health here in Metro Atlanta. So I know all of you are here prepared to write great big checks, so we only need another $6 million and we're there. I feel obliged to say that, but most of us in public health just don't have that, do we? It's our challenge. I also want to acknowledge the Georgia Global Health Alliance for co-hosting tonight's symposium with us. See a few familiar faces from GGHA, and want to thank GGHA for their partnership. And before you leave, please take some time to review the Smithsonian Traveling Exhibit, Outbreak Epidemics in a Connected World. This has been made possible, this exhibit's made possible by several donors, including Securus, whose flu shot I got tonight. And they're represented on the panel tonight by Dr. Frost. Finally, if you haven't already checked out the flu bug, did you all see the flu bug out front? Check it out, yeah. So tonight's program is the inaugural event in a series of symposia in topics in global health. It's going to provide an opportunity for us to learn more. And this is a wonderful opportunity given what we've been doing in highlighting influenza this week, as well as the WHO CDC meeting here this week. I look forward to seeing you all again at future symposia here. And at this point, I think I'm supposed to turn over to Dr. Mark McKinley, the director of our Center for Vaccine Equity, who's going to introduce the Partnership for Influenza Vaccine Introduction, PIVI, and tee up our program for the evening. Mark?
Thank you, Dave. Thank you, Dave, and welcome everyone. As Dave mentioned, I'm Mark McKinley. I'm the director of the Center for Vaccine Equity here at the task force. Our mission is to provide all people with equal access to vaccines. And we work in a number of different areas. One is polio eradication. Hepatitis B and C elimination is a new program that we're working on. Immunization advocacy and education. And building influenza vaccination programs and pandemic response preparation, which is the reason we're all here to talk about tonight. The Partnership for Influenza Vaccine Introduction, or PIVI, is a key component of the work we do at the Task Force in Influenza. We're very fortunate tonight to have Walgreens giving flu shots outside, and if you didn't get yours and would like to slip out the back, be our guest. It's really important because Walgreens was actually there at the very beginning of PIVI. In fact, the idea of PIVI came in 2011 when Walgreens called CDC with a question. We have some excess vaccine, and is there a country around that might want to use it? Luckily, Dr. Lisa Coonan, who you'll hear from shortly, answered the phone and discussed the idea with Dr. Joe Brzee, who you'll hear from tonight, in the influenza division at CDC. The CDC had an active partnership already with Laos, the country, doing influenza surveillance. And so they made contact, and the idea for PIVI was born. In 2012, CDC, along with the WHO country office in Laos, Walgreens, and UPS coordinated together to deliver 350,000 doses of vaccine to Laos. This donation laid the foundation for PIVI and resulted in creating a sustained national seasonal influenza vaccine program in Laos. Joe and I were with the Laos team in Beijing talking about procuring vaccine going forward. And you can read more about this program in the photo expedition outside. In 2013, we were able to formally launch the PIVI program with a grant from the Bill and Melinda Gates Foundation and support from CDC. While the heart of our work in PIVI involves building these sustainable influenza programs in middle income and lower income countries that really help to prevent flu today, we know that by building these programs and putting in place these vaccine delivery systems, this is really critical to being able to respond to a pandemic and other epidemic threats in the future. So we have a short video here that will help kind of explain the relationship between seasonal programs and pandemic preparedness.
Each year, seasonal flu causes millions of severe illnesses and hundreds of thousands of deaths around the world. Occasionally and unpredictably, a new flu virus emerges that spreads worldwide. Because most people have little or no immunity against this new virus, many more people get sick and die. This is called a flu pandemic. A severe flu pandemic could kill millions and cripple the global economy. Fortunately, governments, organizations, doctors, and scientists are working hard to prepare for the next pandemic. Programs continue to advance in countries around the globe to find and respond to new disease threats as early as possible in an effort to reduce the impact of a pandemic. Once a flu threat is detected, new vaccines can be made, but this process can take months, and having a vaccine is just the start. There must be systems in place to get the vaccines to people quickly. Slow systems or no systems mean missing the opportunity to slow the spread of the virus and save lives. In 2009, the world experienced the most recent flu pandemic. It was a time of great uncertainty while the new virus was identified and vaccine was made, and this process took time. Even then, in some places, the systems weren't in place to get the vaccine out to people. This is where the Partnership for Influenza Vaccine Introduction, or PIVI, is stepping in. PIVI works with countries to help them build strong yearly flu vaccination programs, which act as a foundation for pandemic plans that can quickly be put into action. PIVI supports countries as they create plans, strengthen health systems, improve approval processes, and enhance the skills of healthcare workers to deliver vaccines. Programs like PIVI not only prevent seasonal flu and help to reduce the impact of the next flu pandemic, but also keep more communities safe by building programs that can respond to other infectious disease threats. Join us in creating a safer and healthier global community for us all.
Great. So hopefully that gave you an understanding not only of PIVI, but how the public health problems that we face as a global community. I'd like now to introduce Dr. Lisa Kunin to tell us more about the work that's being done to prepare for the next pandemic. Lisa serves as Deputy Director of the Influenza Coordination Unit in the National Center for Immunization and Respiratory Disease at CDC. In this role, Dr. Kunin provides leadership and coordination for the national pandemic influenza preparedness activities at CDC. And this is to assure that the nation is well prepared for the next pandemic. And you'll hear that preparing for a pandemic is really a dynamic process, one where experts in the field are constantly evaluating and testing new plans. In fact, Lisa recently, just very recently, led a 3-day functional pandemic flu exercise at CDC. This was made up of 400 people, including CDC staff, agencies, state and local partners in the private sector, with everyone there learning and preparing to adapt for readiness for the next pandemic. I would also like to highlight that it was Dr. Kunin that came up with the idea, the transformational idea, for vaccinations in pharmacies back in 2009 to get more vaccine into the public. So you can thank Lisa for the flu shot you got tonight from Walgreens. So with that, I'd like to welcome Dr. Lisa Coonan.
Thank you, Mark. That was very generous, and I appreciate it. And thank you and welcome to everyone here tonight. There's a lot of other things you could be doing tonight, but you're here because you want to support and learn about what the task force does, pandemic planning, seasonal flu planning. And these are things that not many people think about from their day-to-day, but we're fortunate to have the task force and to have others who are spending their time, their energy, and their resources in preparing the world for the next pandemic. I want to chat with you a little bit tonight about some of the work that we're doing and some of the important considerations that need to go into planning for a pandemic, because it's not easy to do this. So we've already heard that seasonal flu is impactful. It takes many lives every year. Tens of thousands of people in the US die, and hundreds of thousands of people die worldwide. The thing about seasonal flu is that we have something that we can do about it. It's not a virus with no cure or no prevention. And so because we can do something about it, it becomes very important that we do. And basically, for seasonal flu, it's about flu vaccine. So who needs a flu vaccine? Well, CDC recommends that everyone over the age of 6 months could benefit from a flu vaccine. And although it's not perfect, it is the best way and the most durable way that we have to prevent flu. And getting an annual vaccination is an important health measure. In this country, because of all the places that you can go and get a vaccine, we are very lucky. And there are many places in the world where this vaccine is not available. It's life-saving, but it's not available. So there was mention in the title of this program about last year's flu season. And last year's flu season hit us very, very hard. Anyone who works in flu knows that flu is unpredictable. We never can predict what next flu season is going to be like. Don't ask me that question. I don't have the answer. Dr. Brzee doesn't have the answer. No one has the answer, because flu is different from year to year. That's why this meeting was held with the WHO consultation group. The recipe, if you will, for flu vaccine has to be formulated every year to match the circulating strains. Some years it's a strain that causes a lot of disease, like in 2017-18 season, and some years it's milder, and we just don't know in advance. Flu illness last season, just to set the stage for the discussion in the panel, began to start to increase in November, which is typical what we usually see in a flu season, that it sets off in November or December. But it reached a very high period of activity right after the first of the year. And it remained elevated for a really long time, well into March. Flu illness was at or above the national baseline for 19 weeks, making the 2017-18 season one of the longest flu seasons in recent history. And we thought it would never end. Hospitals were impacted, doctors' offices, and it lasted on and on. It also was a season with high severity, high levels of outpatient clinic and emergency room visits, high levels of hospitalization rates, and high levels of deaths. In fact, people 65 years and older accounted for almost 60% of the hospitalizations due to this flu, and that hospitalization rate for that age group was the highest ever recorded in CDC's surveillance system, breaking all records previously recorded. And although deaths from flu for adults is not a reportable disease, we did unfortunately suffer 180 pediatric deaths in this country during the flu season, and that number exceeded the previously highest number of flu-associated deaths in children during a regular flu season, which was 2012, 2013 was the last highest number. So these are children, approximately 80% of them, that did not get vaccinated. So seasonal flu is very much linked to our concern about other types of flu. And novel flu strains that cause a pandemic are often emerge from animal viruses that infect birds, pigs, or other animals. And they jump to become an established human disease. In the early 2000s, there was a lot of concern about the sudden and growing appearance of the H5N1 virus in Asia, which largely affected wild and domestic birds and flocks. But when it did affect humans, it caused a very high death rate. Luckily, H5N1 did not turn into a human pandemic or pandemic disease, but it still exists, it circulates, and in this country in 2016, we had an avian flu virus that swept through the Midwest and the Pacific Northwest and wiped out billions of birds, either from the disease itself or from the control measures that we had to enact. In fact, when it comes to avian flu, the one that we're really concerned about is H7N9 virus in China. In 2013, this suddenly emerged. And in 2017, and you can see that circled on the slide, we had a very unusually large outbreak. 623 deaths have been reported out of about 1,600 confirmed cases. This really set off concern that this virus could turn into a pandemic and redoubled our efforts. So just in case you're wondering, what's the definition of a pandemic? A pandemic occurs when there's a new influenza A virus. It suddenly emerges in the human population. It causes serious illness. It spreads easily from person to person and affects multiple countries and multiple continents. The severity is greater than a seasonal flu because no one has immunity to this new virus. It's unannounced, we can't predict it, and it lasts a really long time. A natural disaster like a flood or an earthquake, there can be a really bad day or a really bad week, and then a long recovery time. With a pandemic, it can be actively moving through communities for more than a year. And there's no physical damage with a pandemic, but a great human toll. It could affect 30% of the population or more. It would have a severe impact on healthcare facilities if the disease was severe, and a likelihood of societal disruption. An influenza pandemic doesn't have to be severe, though. It could be mild, moderate, or severe, and it still would be disruptive. We've had 4 major pandemics since 1918. The 1918 one is the one we hear about all the time, and it was very disruptive. Approximately 20 to 40% of the world's population became ill. An estimated number of people who died is about 50 million, with about 675,000 deaths in the US alone. And this affected a group that we usually don't see affected by flu. When we think about flu, we think about young children and older persons, but we saw a lot of young to middle-aged adults become sick and die in this pandemic. In 2009, yes, that was a pandemic too, although it was mild to moderate in nature. The thing about the 2009 pandemic was it was not the pandemic we planned for, because flu never does what we think it's going to do. So you remember I said we were very concerned about the H5N1 virus that emerged in Asia. This is what we thought. The next pandemic, it was going to start over there. We'd have plenty of warning, and we could see what was going on. And lo and behold, it wasn't that scenario at all. We also didn't expect it to be mild to moderate as it finally played out. But at the beginning, the severity was very concerning. It was very difficult to assess that severity as well. And there was a lot of heterogeneity in the outbreak. Here in Atlanta, in the spring of 2009, there was hardly any disease at all. But if you were in New York or California or the upper Midwest, there was a lot of disease. So we learned from that experience. We learned we need flexible response plans that can pivot with the situation of the pandemic. And that's what we've been working on ever since. So what can be done to prepare for the next pandemic? Well, we have plans. We have national plans, state plans, local plans. organizational plans, and we've been working on plans since 2004, updating them, refining them, and testing them. Mark mentioned we just had a big exercise at CDC with over 400 people participating. We were testing our plan. We learned a lot. We'll refine that plan. We'll republish it, and then we'll test it again. That is what we need to do to be prepared for a pandemic. It's complex and cumbersome, but there are tools in our toolbox. Pandemic vaccine is our most durable tool for protection. We have antiviral medicines, infection control measures, social distancing. All of these things are in our toolbox, and we will pull them out as we can. But we might not have all of them all at once, and particularly vaccine, it might take a while to come. I want to mention pharmacies since that was called out, and since we had the opportunity for a flu shot from Walgreens Pharmacy tonight, and just let you know how important pharmacies will be as critical providers of medicines and vaccines during the next pandemic. We have had great partnerships with pharmacy organizations in doing this planning. And in 2006, about 6% of adults got their flu vaccination at pharmacies. This past year, it's over 25% of adults. So currently, pharmacies are major immunizers for flu vaccine. And CDC is counting on pharmacies and pharmacists to help serve as critical providers of flu vaccine during the next pandemic. We've done some modeling, and what we have found is that if we have a sufficient number of pharmacies participating with our flu vaccination program during a pandemic, we can shorten the time to immunize a critical mass of people by 8 weeks, and that is not trivial. Pharmacies can help extend the reach of the public health during an emergency. They're convenient, people know where they are, pharmacists are trusted, they have hours that are extended beyond those of medical clinics and doctors' offices, and they're very capable healthcare providers. So we're very pleased to be partnering with pharmacies and making sure that pharmacies are part of the solution for a pandemic. And in many places have not thought about doing that. In countries that we go around and we talk to and provide pandemic planning information to, they've not thought about including pharmacies. And that's a key message that I think we can share. So the goal of our pandemic mitigation measures is to take that green curve and to flatten it and spread it out and push it forward, to buy us time to get the most durable measure that we need, which is pandemic vaccine. And all of the mitigation measures that we'll be using together will be to aim to do that. And like I said before, the vaccine is not going to be available on the first day of a pandemic. It's going to take time, even in the best situation, to produce that vaccine. And this slide shows a little bit of the mismatch between the peak of the disease in 2009 and the widespread availability of vaccine. So, because vaccine will take some time to come out of the chute, we need to make sure that programs are ready to be able to receive that vaccine. And in 2009, there was slow distribution and uptake, in particular in Asia and Africa. Although over 12 million doses were distributed in Africa during the 2009 pandemic, only about 2/3 of them were actually administered. There was low uptake in African countries because of lack of programs, concerns about the need for vaccine, and safety concerns. The population did not have the experience of annual seasonal vaccine programs to get used to being vaccinated. And these delays can be prevented if we go ahead in advance and put a sturdy foundation. So seasonal flu vaccination programs like PIVI and others, they can serve as that sturdy foundation. They can be a critical component to mitigate a pandemic, but there's no time to build them when a pandemic starts. They have to be in place. And those programs, if they are in place, can shave weeks off of a pandemic response. Like I said, we won't have vaccination at the start of a pandemic, and we will have to use other measures. Our non-pharmaceutical measures, such as school closures, Postponing mass gatherings and our border health measures are going to be difficult to implement, but they're going to be measures that can help slow the transmission of a pandemic. One of the things we learned in pandemic planning is that although vaccine is very effective, and although we have antiviral medicines and other measures, there's no single measure that will help us fight a pandemic. We have to bundle those measures together. We have to use them simultaneously and in harmony with each other so we can get the desired effect. So why plan now? What we say at CDC is it's not a matter of if there will be a pandemic, but when, and we don't know when. But what we do know is that the lift is so heavy when a pandemic starts that we can't start from scratch. So we have to plan ahead. It's very important that we maintain our critical infrastructure, our societal functions, our healthcare functions. So we not only have to plan from a public health perspective, but we also have to share our planning with our state and local partners and our private sector partners as well. And planning for a pandemic can serve as a very good vehicle for planning for other kind of public health emergencies. So we are very much promoting pandemic planning. So let me summarize. So there's room and time for you to hear the panel and to ask them questions. We've just discussed that seasonal flu causes a significant burden of disease every year, but we do have vaccine available. And if programs are established ahead of time, they permit the practice that we need for a pandemic. It's not a matter of if we'll have a pandemic, it is inevitable, but the timing and the severity is unknown. We continue to watch all across the world for the emergence of avian flu strains, and we know that we need to prepare in advance. The kind of preparation that we need to do now is complex, it takes time, and it takes resources. But those resources, the tools, and the guidance do exist. WHO has many of these resources, CDC and others. And so we are really glad that to be able to work with the task force, to work with WHO, to work with all of our partners in this endeavor. And I thank you very much for your time.
Thank you, Lisa, for that outstanding presentation, and thank you for all the great work you're doing to prepare us for the next pandemic. We really love if you could join us up here when the Q&A portion after the panel. And now we're going to hear from Dr. Joe Brzee as he leads a panel discussion about last year's flu season. Some of the challenges that the communities faced, and those of us in the Atlanta area certainly know that, and what else is being done both locally and globally to prepare us for a potential pandemic. Joe is the director of PIVI here at the task force, as well as the associate director for global health affairs in the influenza division at CDC. Welcome, Joe.
Can you guys hear me okay? Can you guys hear me okay? Yeah. Okay. Well, luckily you're not going to hear from me. You're going to hear from people that are much smarter than me that we're going to bring up on the panel. So we're going to start the panel in a minute. But first, let me thank Lisa again. I love listening to her talk. I always learn something. She's always passionate and creative. I always feel more energetic. So another hand for Lisa, maybe. Let's see what she's doing. So we've heard about a few things. We've heard about the substantial impact of seasonal flu. We've heard about the threat of pandemics, and we've heard about some of the things the task force is working on to mitigate that, to prevent, to prepare the world for the next pandemic. That's great. Let me throw a couple of numbers at you. And Lisa mentioned this in passing, but let me just throw them out again. CDC reported this year that last year's flu season in the United States was the most severe flu season in 40 years. We've been measuring these things. Since 1976, it's the most deaths we've ever had, the most hospitalizations we've ever measured. 80,000 people died last year, including 180 children, and more than 900,000 hospitalizations occurred last year, including 40,000 hospitalizations among kids. So this was an amazingly severe flu year. And so we're going to hear about that from our panelists. We're going to drill down on maybe why that was and what we can do about it. But I want to start with the fact that behind each of those deaths and behind each of those hospitalizations is a family, is a community, is Atlanta. And so before we invite the panel up, we're going to show you a video. And the video are news reports from last year from Atlanta to give you a sense of at least how the news media was reporting last year. So if we show that, then we'll invite the panel up.
The Georgia Department of Public Health confirms a 5th flu-related death in our state, and that number is expected to rise. So far, no children have died from the flu, but local hospitals are seeing a huge spike in cases, especially amongst kids.
Latest on this deadly flu season, this mobile flu clinic, that's the only one of its kind, opens in about an hour, and it will help emergency rooms with the flu already blamed for 25 deaths in Georgia.
Called Med 1 for Mobile Emergency Department, can handle any type of patient though, and gives the hospital 14 extra ER beds, space that Grady desperately needs now. They usually are a very busy emergency department as is, but they've seen about a 25% increase in patients, mostly with those flu symptoms.
We are talking about the flu again, an epidemic, and this is new map from the Atlanta-based Centers for Disease Control and Prevention. Look at all the red. Most of America, Georgia, of course, in red, which indicates the highest level of flu activity. Breaking here in the last 10 minutes, the number of people dead from the flu in our state of Georgia, 51, up from 37 just 2 days ago.
CDC says the U.S. saw 7 more pediatric deaths this week because of the flu.
By the end of the flu season, health experts say 34 million Americans will have had the flu. They still maintain the best way to prevent the flu, frequent hand washing and getting a flu shot.
Great. So now we're going to keep the learning going. We're going to bring up a panelist, and it's sort of a who's who of public health and flu knowledge in the world. So we're really excited to have these panelists. We're going to start with me asking them some questions, but we really want you to ask questions as well. And so I'm going to do this for a little while, but then we're going to cut it off with about 30 minutes to go at least. And let you answer questions. Start thinking of what you want to ask. This is your one chance to take a bunch of flu experts from around the world and ask them anything you want to know or anything your grandmother wants to ask them. So just let us know. So the idea is to be casual here. That's my nature, generally speaking. But let me go ahead and ask you guys to come up and take a seat if you can, and I'll introduce you once you're up here. You don't have to come up one at a time. It's not that sort of thing. And depending on where you sit, I'll introduce you in that order so people know who you are. Great. So we'll start from this side.
Start the other end, Joe. The microphone thing is going to be a bit out.
Okay, we'll start from the other side is what I meant to say. And so to our far right or to your far left is Dr. Sandra Ford. Sandra is the District Health Director and the Chief Executive Officer of the DeKalb County Board of Health, and was really on the front lines of last year's flu season. So we're really looking forward to her perspectives on the local context of flu. Coming this way, we have our old friend, Dr. Sylvia Bino. Sylvia is the head of the Control of Infectious Diseases and Immunizations Department in the Albania Institute of Public Health, and importantly, one of our partners in PIVI, the Partnership for Influenza Vaccine Introduction. And Sylvia has really been a pioneer in vaccine introduction in the ex-Yugoslavian states in Albania. Coming this way now, we have Ann Mullen. Ann is the chief of the Influenza Preparedness and Response group at the World Health Organization in Geneva. More importantly, maybe not more important, equally importantly, Ann worked at CDC for many years and actually started the international program of the influenza division at CDC and directed it for the first probably 10 or 12 years of its existence. So welcome back, Ann. And finally, if their speaker might be working, we have Dr. Phyllis Frost. Phyllis is the Global Director, Health Policy, Pandemic Response Solutions, and Securus. And as many of you know, Securus is one of the major suppliers of flu vaccines worldwide. And what you don't know, but you'll soon know, is they've taken a really creative, interesting approach by assigning a group, Phyllis among them, to work specifically on pandemic preparedness. And we think that's a really amazing thing. We're going to hear more about what that means. So welcome, panelists, and give them a nice round of applause. We'll start asking questions. And I'll move over closer so I can actually see you guys while we're talking. And we'll ask Lisa to come up for the questions. So if you have questions for Lisa, please ask them. So we're going to start on the other end with Sandra, if that's okay. We'll start with a local perspective. And Senator, we're hoping that since we saw this video, that you could share a little perspective you had on last season. We heard a lot about ERs and clinics being overwhelmed last year in hospitalizations. The question was, that happened in Atlanta, number one, and how did you deal with it, and how would you compare it to the 2009 experience, which was it different? Was it worse last year? But talk about last year and how you all dealt with it, because you were on the front lines.
Okay. Thank you. First of all, let me just say I'm not so short that I need a stepping stool to sit on a stool. I had knee replacement a few weeks ago, so it hurts to dangle. So that's why. So it's like she's so tiny, she has to get help to get my. No.
Give her a glass of wine, quick.
And an ice pack. So let me just say, for frame of reference, 2016 we had 9 deaths in Georgia from the flu. Last year we had 151. So that right there lets you know what we're talking about. We had over 3,000 hospitalizations in Metro alone, and 4 pediatric, well, actually more, 4 in Metro, 4 pediatric deaths, one of which was literally about 5 miles from here, a 15-year-old high school student who died over the weekend from influenza, and totally avoidable, did not have his immunizations. There was another 15-year-old girl in Newman who also perished from this preventable disease. So in terms of manpower, I think everyone was completely swamped, and that portable hospital that was put outside of Grady was just an example, and we had to borrow that from another state just to manage the flow of flu that was going through. And they were seeing, actually they said they stopped counting at 500 patients a day. At the peak. So for last year, what you saw truly was the perfect storm of bad things to happen. First of all, you have H3N2, which is a high virulence, A. B, you have a vaccine that is a little less effective than normal, and then you have a super long peak. So everything that could go wrong went wrong last year, and we were completely unprepared for it. How does that relate to H1N1? Well, ironically, at the time that H1N1 came about, I was actually the state's public health officer. And so we had those first few cases that hit Georgia, and everybody kind of lost their mind because we were looking at Mexico and how hard it had hit Mexico, and we were sort of ready for that kind of response. So happily, as it relates to Mexico, we certainly didn't see that intensity, but it was still a big deal. We still weren't prepared because, we weren't sure when, because it was hitting, as you know, different states at different times, and actually Georgia was sort of on the late end of things. And of course, everyone was waiting for the vaccine. There were issues, again, with distribution and waiting lists and who was on the waiting list and who gets priority and all those kinds of things. So at the state level, it was a very interesting time. This was also one of the first times that at the state level, the public health director had to close a school. And that was a big deal because it was Henry County, and there were simply not enough teachers to take care of the students because everyone was getting sick. The difference, though, that H1N1 was targeted to a pediatric population, and so we were sort of expecting that. This last year with the flu, to lose that many children was a really big deal and very unexpected and so quickly. And a lot of the folks, because of the virulence of the virus, just got sick so fast. And so we'll talk a little bit, I guess, at the end about lessons learned, but we say this every year to people, this is a serious illness and it's not to be taken lightly, and every year we lose people, and that just happened to be a particularly bad year.
Thanks very much. That was excellent. Thank you so much for your perspective. And we're going to get back to you with a couple more questions, but let's move on to Sylvia. We'll come this way a little bit. And Sylvia, as I said, has been really not only instrumental, but almost uniquely instrumental in her region in helping introduce new vaccines to prevent illness, including flu. Sylvia, you might we heard about Atlanta. You might talk about what flu was like last year in Albania, but really talk about also your efforts to introduce influenza vaccines in Albania and what you've learned in that process.
Last year, the flu was really severe in terms of intensity. And Albania was like a red spot in the flu news we published with the whole European region. So my minister was saying to me, when this red spot will disappear. So it was a severe in terms of intensity, but not in terms of deaths. A year before, we have more or less like you described, which had H3N2, and the number of deaths were much higher than during the pandemic. And so this came to bring the flu as a kind of important public health disease and problem in the country. Because, sometimes flu by the politicians, even by ministers of health, is not considered a very serious disease. Because sometimes they look for other issues within countries with lower resources, and they think, why to think about the flu? But the flu came, and the severity of the intensity and the number of deaths and affecting children and affecting vulnerable people made the flu something really important. So, and at the same time, we knew it was flu because we were strengthening the surveillance, and we knew what it was, like H3N2 or B virus, or what kind of B virus was circulating, because this is important. If we are talking about many years ago, we were not able to talk about it. So this was, surveillance was important to document. So this was the situation. It was not just in Albania, it was Macedonia, bordering Albania. It was Montenegro, so all this region, this red spot was circulating within the region. So, but in terms of vaccination, we started ad hoc vaccination. When the pandemic came, we were not really prepared. But in 2014, we thought to have a program of healthcare workers. So we started with a small number of people in terms that our immunization program could afford it. And then for healthcare workers, and it was funded by our Ministry of Health. And then PV came, and we started to increase the number of healthcare workers and to increase the number for other groups that were recommended in our influenza policy program.
And one of the things that, just to stay with you for a minute, if it's okay, you mentioned Macedonia and Montenegro. One of the things that you all have done is develop a regional group of countries, first to do surveillance to show the value of prevention, and now to start introducing vaccine to show that you can actually prevent things. I want to talk a little bit about how you did that, and maybe the role of regional consortia of countries in progressing with flu prevention in the region.
Yes, this is an effort which started many years ago. Because you have to have trust and credibility if you want to establish a network of countries. Even the countries are bordering itself. So, but we are countries that share more or less the same healthcare system, and they share the past and some of the resources. And also we are small countries in terms of, we understood that we have to join efforts in terms to help each other and each country itself. So this is an initiative that started mainly by surveillance of communicable diseases. And then we started with surveillance of influenza and strengthened laboratory capacity. And thanks to CDC, this has been increased year by year in terms of the capacities. The countries are able to say this is influenza and are able to document the severity in hospitals by SARS surveillance or measuring hospitalizations. So this is, because we share in terms of healthcare systems, but also in terms of joint mentality, let's say, and even within the vaccination. And some of the countries even share the same language. So we could share some of the resources. This was the reason that we started to work on the surveillance, and it was the right time to work on influenza vaccination.
Perfect. Thank you very much. And so we'll come this way, and we're gonna get farther and farther away from local flu. Anne, we're lucky to have the head of influenza at WHO with us tonight. And so, Anne, I wonder if you can start just telling us how WHO approaches flu prevention and what you do. Tell us what the Global Influenza Program does to help us all prevent flu and be rid of it.
Okay, thanks for the question, Joe. Well, actually, there's a lot of people at WHO, and it's not just in headquarters, but it's all the regional offices and many of the country offices. But to start with, we've got an amazing 70-year-old global influenza surveillance and response system. It's been tracking viruses since around 1947 or so. And they first started realizing that we needed to make strain changes, and they started formulating these vaccine strain decisions. So this is what Dave was talking about this week. We had all those global experts in this very room working on those decisions for influenza. So this system has been building slowly over the years, and I think it's gained a lot of momentum in the last decade with a lot of global partners. Helping countries be able to do exactly what Sylvia said, identify flu, detect novel viruses, understand surveillance, and now increasingly we're trying to help countries take the data that they've started to gather and look at burden of disease so that they can really understand that flu is a problem in their country. Because if you can't identify it and you don't understand the impact, it's hard to put that flu into a public health priority and where should it fit in your constellation of things you do for public health. So that's one of the things we do at WHO. We have another fortunate in 2011, there was the PIP, Pandemic Influenza Preparedness Framework System, that was developed by member states. And it's a really unique public-private partnership and an access and benefit sharing system where industry or pharmaceuticals or others that use the GISRA system that I just mentioned, that 70-year-old flu system, they share benefits for using that system. So there's two ways they do that. One, they sign these standard transfer agreements that make pandemic things available. So pandemic vaccine available in the instance of a pandemic. Right now, we have agreements signed at WHO for over 400 million vaccines committed from manufacturers. They also provide some antivirals, there's SMTAs for that, and also diagnostics. The other thing we do is there's a partnership contribution, and all of those funds that they pay annually go to helping enhance GISRIS, enhance pandemic preparedness globally. So there's a lot of work going on at WHO with a lot of partners at all the regional offices and in countries trying to help countries build their surveillance and their pandemic preparedness, their capacities for burden of disease and regulatory. So that's just a small snapshot of some of the things we do in our program. There's another group at WHO that's working on really understanding the best way to use vaccines. So there's a SAGE advisory group for vaccination, and there's an influenza working group that was recently formed. So the last time they made recommendations for flu, and they recommended 5 priority groups, was in 2012. But a lot of things have happened since then. So they've just reconstituted a new SAGE influenza working group, and they're looking at all of the current data to see if there's evidence to change recommendations and all of the new things, new vaccines that come online, new issues with vaccines that they need to look at. So we're looking in the next couple of years to get out some more updated evidence-based recommendations for the use of flu vaccine, which will help countries, again, prioritize where to put flu in their constellation of public health tools.
And I'm going to stick with you for another minute, and Phyllis as well, because you mentioned something I want to get back to, but let me just say an editorial comment, I guess, as well. You mentioned the GISRA system. This is the global surveillance system for flu. It's 65 years old, and it really is an amazingly effective influenza system and a real great example of global partnership. So, and TIP framework is amazingly creative and important for different reasons, but also one of the best examples, I think, of WHO leadership in the world. The third example of that, though, is you alluded to, which is this system, this process that WHO leads to create the formulations for the next vaccines twice a year. And I mention that because it's It's amazing to me, mainly because it's an example of a public-private partnership fundamentally, that it's a public health partnership with WHO, ministries of health, collaborating centers with industry as well, which I think is, and it's functioned so well so long. And so I wonder if, I'm going to give this to both of you guys, is if you might talk about that as an example of partnerships that the task force does, great partnerships. What have you learned? Why is it important? What do you want to say about it, I guess? Because I think it's so important. We ought to hear something about how the strains are selected and how WHO works with the industry on that.
Great.
This was not a planned question, so I'm going to keep talking while they think about the answer. So
Keep talking. No, I guess I would say that it is an amazing partnership because it starts in the countries. And right now we have 114 countries that have designated national influenza centers. There's also 6 WHO collaborating centers globally that take samples from those national influenza centers and analyze them further. And these are the data that feed into this week's vaccine strain selection twice a year. So on the one hand, you've got all of these countries in the labs submitting samples on a weekly basis, in some instances, to the WHO collaborating centers. And then the WHO collaborating centers are in constant communication with each other, with WHO, and with industry. There's weekly or twice every other week calls with industry to let them know how things are going, what's circulating. WHO publishes reports. And so then today is the crux of it, where we hand off hand the baton, so to speak, basically to industry, because they take that data that's come from all these countries that has been mulled and carefully considered, and then they make the vaccine so that we can protect people from flu. So it's an annual, twice annual passing baton, and we're always running because the system is so tight. There's not time to delay or dally. I mean, the system is a really serious system. I would say all of the people I know work so hard because they're always trying to get the next answer and pass the baton to the next person to do the next thing in the system. And I'll pass the baton to Phyllis.
Excellent. How much that metaphor was going to look at her. I'm a nurse, thank you. I mean, anybody who's worked in a public-private partnership, so the government working with industry, knows that that's complicated, right? Different goals, different pressures, different needs. The pit that Anne talked about is literally 140 governments working with probably another dozen manufacturers, and somehow they make it work. So it is truly amazing. And from a company side, you're making a vaccine, you want to get ready against a pandemic. The vaccine needs to be against what's circulating, and the only way you understand that is by really gathering that information from all over the world. So WHO is the crux of that gathering. And then when it comes time to make a pandemic vaccine and have it distributed, again, the nexus for doses to go to countries that don't have the means to bring them to themselves, WHO again is the point from companies to donate these doses, which is agreed to in advance, to go out to countries that need them. So yeah. It's a big deal.
It is a big deal, and it's done twice every year, so it's even a bigger deal, I think.
Can I add one more thing? I think another thing that it's really been in the last dozen years or so, I think since H5N1 started to circulate more and more. Every time now when they have the vaccine strain decision, they also talk about all the circulating novel viruses. So they talk about the human infection with an H5N6 or the H7N9 that's circulating in China. And they actually are gathering all the information in collaboration with FAO and OIE. So there's an animal-human interface connection there where they're really trying to see what's circulating in animals. Have humans been infected? And they're making in advance candidate vaccine viruses that can be put away. And there's a whole menu that you can choose from if you need an H5 or you need an H7. And the companies use those to then do pilot lots and test those clinically. So there are a lot of pre-made candidate vaccine viruses to novel circulating viruses in case we might need them one day. And you can never get it perfect, but they're constantly updating in case something that's currently circulating cuts loose and starts spreading in humans. So there's just a lot of back and forth between industry and WHO on making sure that we're prepared there.
Thank you. And so since Phyllis has the chair, so to speak, right now, let me stay with you for a minute. So vaccine manufacturers and biotech companies really play an enormously important role, as Ann just indicated as well, in flu prevention, whether it's vaccine production or antiviral production for treatment, whatever it is. That said, Seqirus, again, I may be wrong about this, so correct me, but Seqirus is unique in that it's purposefully established an organizational structure that is meant to tend to what the pandemic needs of the company and of the world, really. And maybe you could talk about how that came about, but also talk about more generally vaccine producers' role in preparing for the pandemics.
Sure. Thanks, Joe, and thanks to the task force for inviting Seqirus and inviting me. Yeah, it's a partnership. It turns out that if there's a pandemic, the only people buying pandemic vaccines are government. So we have one client for a pandemic business, and you need to get along with your client, and so that's it's a lot of what we do. When you talk about the client, the customer, if you think about seasonal vaccines, it's really quite different. So we work with, and a different part of the company from me works with companies like Walgreens and any doctor's office out there, state health, who buy vaccines on a seasonal basis. So it's literally it's all partnership. So the customer is different. So what Seqirus did, we're a company that's exclusively focused on flu. So lots of companies make vaccines. A bunch of companies make flu vaccines seasonally. And if you make seasonal flu vaccines, you have an obligation. The government's going to pick up the phone if there's a problem to be making a pandemic vaccine too, as fast as you possibly can. And so the company took a good hard look and realized that the two are linked, but they're really different. And so my boss, Marie Mazur, who has told me that she was listening right now, so I hope that's a good name drop out into the stratosphere. Basically had the idea of building a group around, usually companies work around product, and so we're effectively a product team, but for a pandemic. And what it means is that we think about being a pandemic influenza vaccine manufacturer in a way that I think a lot of other companies don't have the luxury of doing. We think literally about nothing but flu all day, and it's really weird to be on a panel with other people who think a lot about flu. Usually I have to convince everyone that flu is serious, and that box is checked. So yeah, the main job of companies making vaccines, and honestly making better vaccines, and that is easier said than done. And so for us, we found that at Seqirus, our pandemic business works with governments that fund faster and better flu vaccines. It's how we have a diversified portfolio of adjuvanted vaccines and cell-based vaccines. That all comes from the pandemic side of the business and that global need to be faster and better. And so for us, it feeds for us to be able to have different and better. I'm probably not allowed to say better. Had I not freaked out.
Except the CDC people in the room, right?
I did, I know, yeah, someone the CDC is getting the big hook. Just different newer kinds of technology to bring to seasonal flu. So it works together.
Brilliant, thank you. And you mentioned Marie Mazur, and if Marie, you're listening out there, Marie was one of the early influencers of PITI, so we appreciate you listening in, and thank you so much for Seqirus support. I want to get back to planning. So we talked about last year, we've talked about the roles of each of these steps, and it's amazing how unintentionally, how seamless this is, because we have the local health that actually treats the patients, prevents disease in the patients. We have the national health folks that actually count the diseases and implement the vaccine, become red spots on the map. And then we have WHO who counts all the red spots on the map and does something. And then we have the industry who uses that information to make things. It's amazing how well this worked out without me actually intending how to seat you guys. So thank you for organizing yourself so nicely. I want to get back to local stuff, and Sandra, I'll get back to you actually. You talked about last year and how difficult it was. What's this year going to be like? What did you learn from last year? And I don't want you to predict things because I know the answer to that. But how Have you done things, have you put in place, or have other people in Atlanta put things in place that if the season were as severe as last year, you'd be better off this year?
So here's the thing. When you just now you said seamless, and I was thinking you were meaning a literal sense that, oh, this flows so well. It doesn't. And so, as I'm listening, you always learn something no matter where you sit on a panel. And so I'm listening to all the energy that goes into that end of trying to develop the vaccine and which strain do we use and how do we put this together. I have to get people to take it. Yeah. It doesn't matter. And I'm not saying what you do is not valuable, but the whole time we were dealing with everything last year, all I kept thinking was every time a report comes out that says this vaccine is not as effective as usual, how am I going to get people to take this next year? That's all I think. All the energy that goes into the preparation, if people don't believe that it's going to work, they will not take it. And so that's a constant struggle for us. It's not a positive, but I think the fact that it was so violent and so many people died will make my job a little less stressful, because you lose a child, you're not going to have as much trouble getting somebody to take a vaccine. Mm-hmm. The issue with H1N1, which had half of the deaths, we had 80-something deaths in 2 years from H1N1, and we had 151 in 1 year just from the flu last year. But the thing with H1N1 was when the vaccine came out and they had the categories of priorities, it was a childhood flu. Parents don't like to give their children new vaccines. And so the main population that needed to have the vaccine wasn't going to get it because the parents weren't going to do that. And so the seniors who really wanted it were not in the first list of first row priorities. So now we've got a whole cadre of vaccine just waiting, but you can't have it because not your turn, but the people whose turn it is can't have it. And so all these things at the local level factor into how do we get messaging out to folk. And I did so much media last year related to flu, particularly once, we had a pediatric death in the county. But the thing is, when that one person calls and says, well, the vaccine doesn't even work, I'm back to ground zero again. And so trying to get people to understand that a little bit of protection is always better than zero is our constant battle at the local level.
It's funny you should mention that because it's one of the principles of PIVI that Mark mentioned, actually, is that one of the challenges in 2009, everywhere in the world, was that, especially in countries without existing seasonal vaccination programs. So you mentioned the fact that it was seen as a new vaccine for kids at the time, or for whoever, pregnant women is another good example.
Right.
Made it difficult to convince those populations to get it. In countries that had no seasonal vaccination programs at the time, it was really hard because it was seen as a vaccine from somewhere else, experimental. So I'm turning now to Sylvia actually for this, because I think that one of the principles of setting up seasonal influenza vaccination programs is not only that it's an effective tool to prevent disease every year, respiratory disease and whatever else every year, it's because it prepares you for pandemics or special situations where you have to reach out to pregnant women or kids or whoever to get vaccinated. So you might talk about, Sylvia, if it's okay, your work in the region to establish the seasonal vaccination programs and what you're hearing from the countries when you talk about, well, this is going to be good for pandemics too, don't worry about it. Is that a resonating message or is that a difficult message?
There have been resonating messages, especially after the pandemic, because we were not all prepared. Mm-hmm. And as you said, during the pandemic, there were a lot of myths. This is an experimental vaccine, and also the countries didn't have, as Lisa mentioned, all these logistics and systems of distribution of the vaccine, etc., that you get used when you establish a program, you do seasonal influenza vaccine. Because in the countries of our region, they have a good experience in childhood vaccination. And we had a very high coverage. Even recently, the region is seeing a decrease of coverage. And because of that, we had a meeting of the ministers in February this year that they were committed to increase the coverage and to put all the efforts on that. So, and because of decreasing of the coverage in general and the myths about vaccines, This influence also influenza vaccine, which is a little bit harder because people don't like another vaccine, and at the same time, they do not believe in the efficacy of the vaccine. So we have to prepare counter messages in terms of, as we said, this is the best thing that we can do for now with the vaccine. So, and the most important is to prepare public health workers. This is what we did in the beginning, because we even had public health workers that didn't trust on the vaccination, influenza vaccination, etc. So, but we have public health workers that now they are familiar and they do trust on that. And by establishing seasonal influenza programs, you start to understand, the operational, the logistic, the scale, and you touch the whole healthcare system, the whole health system by doing influenza vaccination. So it's not similar with childhood vaccination because you have to go to primary care physician. Sometimes you offer in the pharmacies, but also for healthcare workers, we offered in the place they work because they didn't have time. So I learned from Kelly. She was visiting us at that time, and I was asking about some help in terms of how to make all these healthcare workers and coordinate among themselves. So you build a program. So you build basically the capacities during the pandemic. And I remember during the pandemic, the government bought certain doses of vaccines, but it was really difficult to distribute, get the message. The system was not organized, and even to absorb what WHO was offering.
In fact, it's interesting, and this question is for everybody, actually. We've mentioned the difficulty with convincing people to get influenza vaccine, or convincing even doctors to give it, or the nurses to give it. And we see this in the U.S. as well, obviously, when, and Sandra, you mentioned it, because people respond to a crisis. And so in 2009, when there were a lot of reports, both in the U.S. and abroad, about pregnant women who died from H1N1, we finally were able to convince obstetricians and gynecologists to say, maybe this flu thing's okay, and we could get the vaccine. And suddenly vaccine coverage went up to well above 50%. Since then, not so much. And since then, CDC reported today that vaccine coverage among pregnant women has really leveled off since the pandemic, or declined a little bit and leveled off. Same with kids. Kids this year went down a little bit among the youngest kids, which is discouraging. So, smart panelists, advice you would give to doctors or patients about why they should get the flu vaccine. What are the things you're hearing that's the biggest impediment, and how do we change it? So who wants to start?
Well, I'm a pediatrician, so.
Excellent.
I think that sometimes the medical community is my worst enemy, because a lot of docs tell their kids, you don't really need that. It doesn't work that well. I mean, they're not on our side sometimes, I think, in terms of really forcefully recommending. I will tell you that right now, the best thing that's happened to flu this year is that Drake got the flu. The rapper. And all I keep thinking about is how I'm going to get to his agent to get him to convince people to get a flu shot. Right? Because, he had to cancel a concert, and that was like a big deal. And I thought, yes, Drake got the flu. I mean, this is how we work at the local level, is which big person got something that we need, that helps us. Right. But the medical community has not always been a great public health supporter of a lot of things. And it's a struggle, particularly as a pediatrician. But people are protective of their children, but you're not protecting them in the right way.
Sylvia, any thoughts? How do we convince people to get a flu vaccine? What do we need to overcome?
You're asking me still?
No, that's Sylvia.
I mean, you have to put facts in terms of and presenting stories and in general, and make them understand. And I think you cannot do immediately. And even with healthcare workers program, I think in the beginning, in the biggest university hospital, we had the lowest coverage.
Mm-hmm.
And our biggest professor were not fan of influenza vaccination.
Mm-hmm.
But we have seen over the 3 years that this coverage has been increased. And by working and by seeing even the results of the vaccination among themselves and their families, etc., and about the facts. So you have to try little by little. You cannot immediately reach the goal, but you should not give up.
Okay.
And this is how we did over the years.
And Phyllis?
So I think two things. One, I think like the news clip you showed, everybody probably has a personal story. The one that I think about for myself is during the 2009 pandemic, my husband's secretary at work, who he adored, lost her 36-year-old daughter to pandemic flu. She was healthy. She was a marathon runner. She died. And so everybody knows a personal story like that, which is really, it's frightening, it's compelling, and it shows how deadly flu can be even in healthy people. So I think those personal stories, I think, resonate a lot. And the other thing I think is, I think we need to figure out better ways to communicate about the flu vaccine. You can't say it's only 44% effective. We need to turn it around. If you get the flu shot, you're 10 times less likely to, I mean, just put it in a more positive light instead of it's only this or it's only that. Because I think the messaging, we almost shoot ourselves in the foot the way we look at it instead of putting it more in what the vaccine can do. Because right now, I think Lisa said it, and I think you guys said it, it's the best tool in the toolbox right now. I mean, we need to use all the tools in the toolbox, but until we have that, universal vaccine or that really wonderful improved vaccine, we need to keep pushing the envelope on proving what the tools we have. But in the meantime, we have to use the tools that we do have and figure out how to message that correctly, I think.
Yeah, good.
I mean, the science of how we absorb information, how we learn, why we pay attention, like, that's not new stuff, right? Advertisers, marketers, teachers, how do you get in our brains? How do you get a message to resonate? This is not new to the human experience. And so I think, I'm with Anne in that, messages about the low efficacy of the flu vaccine help no one. And there are ways of communicating that are glass half full rather than glass half empty. And you think about a flu vaccine being 40% effective. 40% less likelihood of getting the flu, like, put it in my arm right now. What if we had a vaccine that was 40% effective against HIV? I mean, that'd be a game changer. So it's a question of how. So that's one. One is how you get people's attention to what's important about flu vaccination, and there's a lot that's important about it. And the other piece of it is. So I travel. I live in DC, so I take a lot of Ubers. And you're sitting there, you have the conversation. So what do you do? Oh, I work in flu vaccines. Oh, so yeah, no, I don't get all of those. Yeah, I mean, right? It drives you right, and like she and I are like, that is not cool. And so you don't want to be the arm twister, being like, man, you are really missing out, because that people tune out, right? You need to go eat your vegetables, and you go to the gym and all that stuff. I think there are misconceptions that easily emphasize in people's mind. And one is that the cold is not the flu, right? People who it was described to me as if the cold, you have a cold, you're sick in bed. If you have the flu, you're sick in bed and the house is burning down and you're still in your bed. Like, the flu is not the common cold. It's really different. 2 weeks off work is a big deal to you, no matter who you are, right? It's a compelling message, and it's an accurate message. And that young people or old people or pregnant women, or that, those are people who are in the most robust, healthy years of their lives. I'm looking at you, college students, that they don't get flu. That just depends on the strain. So there are compelling messages, I think, that can help docs, and that can help us going into our doctor's office and saying, yeah, no, I want the flu vaccine because I don't want to get the flu.
Right. Right.
Right. I think that risk factor piece is a big deal because I think that there's still this belief that only certain folks get the flu.
Yeah.
And we always talk when we're trying to convince folks, do you have a baby in the house? If you have a baby in the house, you need to have the flu shot. You know, I don't think people understand the whole definition of immunocompromised could be something as simple as, are you on an inhaler for asthma? You know, I mean, a lot of folks are asthmatic. So we haven't really done a good job of explaining that everybody is at risk. It's not just, our deal usually is public people, like, are you shaking hands? Do you come in close contact? You need a flu shot, you know, so those types of things. And we need to do better about, again, with the messaging. I totally agree.
Super scary statistic I learned last week. The most germ-infested thing in an airport. Anybody read that?
The bathroom door.
TSA bins.
Oh, ew.
Really? So, yeah,
Great.
It's not what you expect. So,
Thank you for that.
shaking hands or anything that are getting sneezed on by babies. So, you're welcome.
Well, thank you for that. With that wonderful image in your brain, it is the time we're going to turn to you guys for questions for our panel. And before we do that, ask Lisa to come up and join us, if you will. At the end of this, and this is something you guys are prepared for that I haven't told you about yet either. At the end of this, you get a final comment if you want. And the final comment could be, what do you want everybody to know about flu, or what do you ever know about the flu vaccine, or whatever you want to say, as long as it's about flu and flu vaccines. So this is your chance in the audience. You have access to some of the great minds of flu in the world. Questions? Anybody? Yes. And you have a microphone behind you. Stand up so I can see it.
Hi, yes, I'll be dragging my family to get their flu vaccine this year, so.
Another one convinced.
I guess I had a question on the 6-month lead-up time. What opportunities do we have to shorten that to 2 weeks or a week, or, you know, as soon as we see it, we make it? You know, what opportunities are there in that area?
Yeah, it's a great question. I feel like, eyeballs on me. So the question, in case you didn't hear, is how do we shorten the lead time to getting a pandemic vaccine out? The answer is right now that it's about 4 months from the time the WHO declares a pandemic to the time that manufacturers can roll out enough vaccines to start vaccinating people. And that's across all technologies and platforms. Some of that is that every year and every strain of flu is a new product. And so we have to do a clinical trial to make sure A, that it works, and B, what the right dose is or how many doses you need. Some of it is that in order to allow us to get that vaccine out, you have to immunize a sheep, and to get the reagents to be able to say how much. So it's a process. So some of it is the amazing technology, and some of it is the fact that policy and regulation change really slowly. I think we all have to want to, and then getting better, faster flu vaccines. I think we would be on the verge of a next generation revolution in the kind of flu vaccine you would want. So we can get incrementally quite a bit better, but I think to really get into that sort of short term, you're looking at a new technology. And if you think about the economics of flu vaccine, I work for a company that's probably not a surprise to people how companies work, is that in order to bring a new product to the market, it costs a lot. And the clinical trials take a long time. And so often, we partner with governments around R&D. And so funding that goes to agencies like BARDA really makes a difference towards getting new technologies going forward. Because it's a bit of a long, expensive slog, but stay tuned.
Yes, please. And then.
Well, first and foremost, I really want to compliment Lisa for the wonderful presentation, and then you, Joe, you're doing an excellent, superb job of moderating the session, and each one of you. Now, the reason I stood up is to publicly really acknowledge one thing, which is, and I wish that I even had a fraction of your memory. The reason I said that is because when you recognize me out in the hall, and then you recognize me as the CDC director in Ghana, and when I might have had some more here, and today I almost not. And then you still recognize me out of the hundreds and hundreds of people that you meet every year, and I'm really grateful to you. And I wish to God that He gives me even a fraction of your memory of recognizing faces and people. So I would say that I'm here because I really want to share. You all are talking about personal story. I have that. I am an epidemiologist and a surveillance person in my background. Having said that, which is that I always think globally, but act locally. I want to act locally. I was in Hajj a few weeks ago. The reason I mentioned that is this was my second time, and each one of those two times when I was there or was returning, me and my wife, we both felt sick, very sick, deadly sick with the flu. We still do not know what virus it or what strains it was because nobody tested us, and then we didn't go and report ourselves. All right, and that would have caused more trouble. But in any case, what I'm saying is that the virulence of the virus was extremely high, or else maybe because we have grown old, we are really weak now. Whatever happened is our son went to receive us, and guess what? The typical the incubation period of 4 or 5 days later, he comes sick. More sick than we were. Worst, I went to visit my mother, 91-year-old, in her nursing home, and unknowingly transmitted it to her. And here was a 91-year-old nursing home resident who is now damn sick with a vaccine, not in your jurisdiction though. Anyway, so the reason I'm saying is that that made me think before I came to this evening, and I'm thinking about the preparedness for the next pandemic, which is basically to say that we all know, myself being a surveillance person, that pandemic is just one flight away. And then I was a very typical example of that. And if you all remember, about a week after I returned, you all saw the news how a flight from Dubai was actually quarantined in New York, and just the next day, 2 more flights in Pennsylvania. Right. And I was thinking, to me and my wife were saying that we could have been one of those here in Atlanta, because in our flight, we were a number of people that were returning from the Hajj, and almost each one of us were coughing and sniffing. And then I can bet and swear to God that each one of us were carrying whatever the strain was in circulation there. So here I am as a surveillance person, mostly to you, Lisa, is thinking globally. What are the steps that are taken? Because as I said, I truly believe that any pandemic is just only one flight away. And having said that, I was thinking, because I did not see any effort at the point of departure in Saudi Arabia. There are only 2 points of departure after Hajj each year. It's either the Jeddah airport or the Medina airport. But there are several points of entry, but not too many. I mean, there is not that flights go directly from Jeddah or to Medina to all 100 countries, to many few countries. But at the point of entry also, what I was thinking is there was never any mechanism of screening, at least the basic questionnaire, are you sick with a flu-like illness? And if you are, describe some of those, and at least leave your contact information. That's the surveillance part of me speaking there. So I was just wondering, Lisa, or maybe any of you can say, is there any such mechanism? Because I hated to have brought that strain here in the US. Knowing myself as a physician and a public health person, I isolated myself after having transmitted to my mother. But then I did one thing. I immediately got in touch with the medical director of the nursing home, and I said that please, all the staff that comes in touch with her, keep an eye on them, isolate her in her room, and so on and blah, blah, all the public messages that I need to say. So what are there in existence? Maybe Lisa, you could also jump in here in the US for people like us, because I truly believe that hundreds of cases might have been missed, cases like me. I know that it's not a reportable disease for adults, but then each one of had the potential of spreading the disease and then turning it into mini epidemics or, God forbid, a pandemic. So
all right, I'll take a stab, and maybe Joe or others can jump in. But, border health issues are a layered approach. And every day at major airports, CDC has a cadre of epidemiologists and health professionals in our quarantine stations. The CBP people that receive overseas visitors and process passports are taught to be alert for those who look exceptionally symptomatic or sick, and they refer them for medical care. The thing about flu is there's a large proportion of people who can be sick with flu, but yet not be very symptomatic or appear very symptomatic. So it's a very difficult disease to catch. And because we were not alerted as to any kind of novel influenza or different kind of influenza that was circulating in those areas, there was not any particular focus on trying to detect that. I don't know what you had. I'm glad you recovered from it. But you will notice at the airports that we have lots of signs. If you're sick, don't travel. In 2009, we had a very robust campaign of sick people stay home, don't travel, wash your hands, cover your coughs and sneezes, those kind of things. But like I say, it's a layered approach.
I mean, it is done. I just flew into South Africa about a week and a half ago, and before you get to immigration, your fever is taken. The security guard asked me to please take off my glasses. So it's right. It is done. It just has it has to be a priority, and you have to think in terms of things like the Hajj.
But if you go into countries like I've been to Taiwan and Japan and other places, you go through the thermal scanner. I mean, the studies have not shown that those broad screening efforts are very effective, actually.
I think there's things I don't talk about, like politics, religion, and border issues, because there's no convincing people on either side. But I will say about the Hajj, what is being talked about seriously at WHO and other places is, and some countries already do this, is require people to be vaccinated. They're going to the Hajj, and that seems like a reasonable thing to do. If you're sending someone to the Hajj or go ahead and get vaccinated ahead of time. It might decrease the transmission during this. So I think that might be a more effective public health strategy than a leaky border system. But who knows? And I think it was somebody behind you first. Then actually, one behind. We'll go this way. Oh, you have the microphone. You.
Turn it on. Turn your mic on.
Okay. I have a question around messaging around effectiveness, lower effectiveness. I've heard people arguing with each other that, well, if the vaccine is 44% less effective, that means that if I get sick, I'll be 44% less sick. Another person saying, no, it means that you're 44% less likely to get sick, but if you get sick, you'll be just as sick as if you hadn't had the vaccine. And it was like one of those tastes great, less filling arguments, people were like back and forth. And I walked over thinking, I really could use some help on how you message around this. Next time I'm like tempted to just throw myself in the middle of an argument that I was not invited to be a part of.
It's my daily job.
So anything when people talk about a vaccine that's less than perfectly effective, how do you interpret that for sort of the general public, what that means to them and their families?
Any thoughts?
I think, Joe, you should.
Well, I think it's a good question. I will take a crack at this, if that's okay. As Anne implied earlier, communicating effectiveness numbers is really, really hard. And with flu, it's even harder because we don't know a lot about what that number means in the sense you just said. We do know that if a vaccine is 50% effective, you can say you're 50% less likely to get the flu. That's easy. What we haven't known until recently, there's light at the end of this tunnel. So for 10 years, I've been saying, you're right. Probably if you get the flu, but if you get vaccinated, but you still get the flu, you're probably going to be less sick. So that's good. But we never had data to show that really, except from old studies in the 70s in nursing homes, which were sort of imperfect. And so every time we were asked, we'd say, yeah, it kind of makes sense. It's probably right, but I don't really know. And that wasn't very satisfying either. Recently, though, there have been a handful of studies that actually showed that were convincingly showed that if you get the vaccine, you're 50% less likely to get sick. And therefore 50% less likely to get hospitalized, die, whatever happens after that. But if you do get sick, if you're the other 50% that still get sick, you are less likely to get sick, to get real sick, to get hospitalized probably. So I think finally, and you'll see CDC pivoting with their communications over the next year or so, we're finally going to be able to say, yeah, it's a leaky vaccine. It's the best we can do, but even if you do get sick, you're going to get less sick than you did before. And I think that'll be a slightly more satisfying way to hear the message. So behind you.
Hi, thank you so much to you guys for being here and answering our questions. So, Lisa, you had mentioned the issue in 2009 of a really low distribution and uptake of the vaccine in Africa and Asia. And I was wondering, and anybody can speak to this, what measures have been taken, or if none, what could be taken to kind of address these issues, especially in areas where historically Western biomedicine has been the foundation of medical care?
Well, I'll start off by just saying that you've heard about PIVI tonight, and that's one effort. But Anne?
Sure. I think it goes back to what I was saying about projects like the PIP, Partnership Contribution Framework. I think part of the problem is that countries didn't understand. I mean, I'll never forget this conversation I had with somebody from India. And it was in 2004 when we were starting our international program, and we're talking to them there, and they're like, "Oh, we don't have any flu in India." I'm like, I think you probably do. So I think it's a matter of not even understanding the severity of flu or the impact it can have on your society. So through partnerships like the PIP framework, we're able to help countries, like Sylvia said, understand that flu is causing a problem. And then as the surveillance gets better and their understanding gets better, even help them understand the burden of disease in their country. And we've had a big push to help countries estimate their burden of disease. And oddly enough, everywhere a country does look to see if flu is impacting their country or their population, they find out it is. So it's a matter of slowly helping build that capacity, but it's a really slow process. You can't build capacity overnight, and you need years of good surveillance data to get a decent estimate. So we are making a lot of progress. When I started an international capacity building program at CDC, and we started working in Africa, there were only 5 countries that were even reporting to the global surveillance flu system that I mentioned. Now there's routinely 26 or 30 of them that do that. They can diagnose flu. They're doing surveillance for flu, and some of them are starting to do burden of disease estimates. The other exciting thing, I'm going to get my plug in because I have to get this plug in everywhere. Flu is like a poster child for capacity building. I cannot tell you how many of those countries that we were helping develop flu capacity, PCR, and basic capacity for flu. And they said, oh, we were able to use our rapid response team for Rift Valley fever. We're able to use our rapid response team for Ebola response. We're able to, I know one time I remember being frustrated because the flu lab, we just got up and running and they were just routinely reporting. They shut it down so they could just test for Ebola. And that was a good thing that they could test for Ebola. But so, I mean, I think the point is that we are working globally. A lot of partners are trying to help countries build capacity, and it's a slow process.
Mm-hmm. Good. All right.
First, I want to thank the panel again. It was just tremendous work. And of course, Joe, for everything on keeping all the horses in line here. I guess this question falls into Dr. Ford's bailiwick, but maybe others may have some insight. And we tend to have a more litigious society in North America, or at least in this portion of North America. And I'm just wondering why it is that, I mean, the incentives are good to try and encourage people and you won't get sick, but I'm wondering if the other side of the stick approach may be, hey, if you have the flu and you spread it to one of my family members in the hospital, I'm going to sue your butt. And you know, maybe we don't have that mechanism, but I know that certainly within the U.S. military, it's a condition of employment if you're going to be in healthcare. And I'm just wondering if other nations are looking at making it more as a condition of employment to protect, because not everybody's going to be able to get the vaccine early on. It's going to take time. But certainly, if you're in those groups and you're not getting the vaccine, I think you're morally responsible, even if not legally responsible.
That's a great statement, and actually it was probably going to be my final word, so you just took my final word. I think that if people understood the fiscal impact from a workforce perspective of the flu, it would be mandatory. Because if you get a few sick people in an office and you have pressure to not be sick, so you drag your sick self to work, you cough, you spread it to everybody, then your whole office is out. Now nobody can work. And so I think if we really understood what it means as an economy issue, it would be mandatory. I can't even get my own staff to take that thing, literally. And so some of the health districts, because we're all free flowing, so it's up to each district whether or not we mandate this. So one of the districts, who shall remain nameless, got on the telehealth for the entire state and said, well, you don't have to take the flu shot if you want to, but if you get sick and you didn't take the flu shot, I'm not going to approve your sick leave. No. No. So yeah, I mean that was a little heavy-handed. So we've got to figure out a happy middle ground here. But once we start mandating things, you start having the civil liberties issue, and then you get litigious on the other side. Like, now you're forcing me to take this vaccine. So I think it's a double-edged sword. But you're absolutely right. I think at some point it's going to come down to large industry are going to have to mandate this thing, because it's taking folks out, and this year was a great example.
Good point. Ellen. Oh, John, I'm sorry, I didn't see you. So John next then.
On that same topic, an increasing number of healthcare institutions are mandating that healthcare workers must be immunized against influenza as a condition of employment. And these policies have been remarkably effective. They have been challenged both on civil liberties issues as well as on labor management negotiations, because if management says something, organized labor usually says no. But they have been remarkably effective, and in terms of raising coverage, I'm not sure that we have many data yet on what this has meant in terms of impact of secondary spread of influenza among healthcare workers or from healthcare workers to other patients.
Thank you. And John, were you waiting for did you have the microphone earlier? That's good.
Thanks again, a remarkable panel. I was struck by something that Lisa said early on, which is, relative to other CDC recommendations, the flu vaccine recommendations are remarkably simple. Every person, essentially, every person and every healthcare worker should receive influenza vaccine. Now, in the era I was growing up, we would say, wow, let's make a bumper sticker, okay? We're not in that era anymore, but are there communications means or ways that we can leverage the simplicity of that message, either pilots that have already been tried or just ideas to try to, again, get at that fundamental simplicity of the recommendation?
It's a good question.
I'm interested to hear your thoughts.
Anybody in the panel?
Don't look down here. It is. It's a local level kind of thing, and it's a marketing thing. I think when you start saying everybody should have something, then people automatically say, well, probably not me. I'm not in that group. But I do think that that's probably the easiest way, is just to say, if you come in contact with people in the course of your day, then you should have the shot. And that's, even if you go to the grocery store, pump gas, what have you. And your discussion about the filth of a travel bag, I mean, that's true. And if you think about that, you think about, we say the dirtiest part of the bathroom is, the handle on the door. And so you think about all the things that you touch in the course of a day, then yeah, absolutely, everyone in here is at risk for something. And so that is the best way, is to just market it to everyone. So we're probably going to try to focus it like that, because these high-risk populations, it doesn't seem to be getting us anywhere.
I think it's the best thing, but for us, that because we cannot offer to everybody, then the message can turn around. So we have been trying to keep a balance on that.
And I think key influencers make a difference. Different audiences respond to different types of messages and different people delivering those messages. So really identifying stories, which I think are very powerful, key influencers, and as you say, a simple message that can resonate with you. And, we struggle with this every year.
We do. One final question, then we got to say, so you raised your hand first. Or did somebody already have the microphone? I apologize again. Okay. Okay, two final questions then. I'm weak.
I have the last question, so now there's two final questions. So mine's a two-part question though. So we've already kind of talked about policy and the big P policy, but I wanted to dive into that a little bit more. Because, for example, Georgia, the state requires hospitals to offer the vaccine, but doesn't actually require that hospital healthcare workers to receive the vaccine. So in terms of the role that Big P policy plays in pandemic preparedness and response, what are your thoughts from a global perspective to a local perspective in terms of the role that plays? And then also, we talked about capacity building, and I worked at the state level for a while, and it's tough during a pandemic. There's not enough resources sometimes to even respond to these events in a timely manner, I guess. You get so behind trying to run flu samples, for example. So what are some of your lessons learned, particularly Dr. Ford, that you could pass on to maybe other jurisdictions?
Lessons learned in terms of capacity building.
What have you learned from this experience here? Like, we need to make sure that we have enough resources or whatever to prepare for the next.
Well, DeKalb, for whatever reason, has such a great reputation in terms of flu immunization distribution that we actually do outside of the county. We go down to the Capitol, we take a bus up to Forsyth. I mean, we really have put our show on the road because we have a pretty efficient system for delivery. So I think that's one thing is we don't really respect boundaries when it comes to that. We'll go anywhere people ask us. Your first part of your question was about the Big P policy. Well, I just spoke to that, I think.
Childcare vaccination laws. So there are some states that require children in childcare to actually receive the annual flu vaccine. There's only two.
Right.
But
we're, like I said, even within our own healthcare agency, we're doing the strongly recommended. And at some point, I keep saying to the medical director, we're going to have to pull the trigger on this and just mandate it. We someone Mr. Nice Guy, because literally every year we lose about 10 to 15% of the staff in any given period of time when that flu hits. So we're getting to the Big P piece pretty soon.
One final question, and we'll turn it.
Somehow I ended up with a microphone, so I hope I don't offend anybody, especially those in industry. I just wanted to ask a question. So we've talked about the big obstacles that we face, and efficacy being one of them. People asking, was it 40% or 50% chance that this is going to help me? But what about the people who ask, is it meant to help me? Especially in my community, I'm just being honest. They ask the question, is this vaccine meant to help or harm me? And historically, that has been a problem. So how do we face that messaging when we talk about mandating, but how do you mandate when people are genuinely scared? Or they're afraid that, private industry can be bought, so how do you face that fear?
Good final question.
Yeah, everybody gets yes. One, you build trust and you work with communities. And this is not coming from the work I do now at Securus. This is from when I worked at the National Institutes of Health, and we were going into groups asking them to donate their genetic data, and that you have to understand the community itself, and you don't do that by being 100 miles away and sending an email. You work with the community leaders, and I'm sure the panel can speak to that.
Yeah, I would say, I think there's a lot of countries and doing studies on vaccine hesitancy and why people do or don't take vaccines and what some of those key issues are. And I think it is maybe sometimes different by community, different by culture. And I think understanding that is the path to helping fix that in those places where we can learn something and make changes in how we approach
vaccination and supporting vaccination program.
Good.
Yes.
Sylvie.
I think you have to work with communities. For example, we work with mediators in some of the communities, especially rural communities, because sometimes they think of the vaccine harm us or whatever, all these messages. So we train mediators from the communities and we pair them with healthcare workers in terms to involve the healthcare system. So you cannot do by email, as she said, and whatever, but you have to work and to transfer the message every day.
So, I mean, that's an excellent question, and it's a true concern. What I have done, I've been in this position for 14 years. So over the time I've been here, I've made friends with every key DJ on every urban radio station, and I have gone down to the station and given them a flu shot on the air. So that people can see this is safe, and people call in, "Why don't you do that shot? It's not safe." Don't but they see they didn't get sick, and so year after year after year we do this. Every year we give the Board of Commissioners a flu vaccine on air on our cable station, so that people can see us doing this. So that's the best way is to see the people that you see in leadership positions, right? And trust me, we're going to hunt down Drake, and we're going to get Drake to do a promo for flu shots, because that would be, if we could do that, it would be golden. That's a key influencer, and that's the community that you're speaking of. If we get an R&B star to get a flu shot on the air,
or the moms to believe that autism isn't
right. Well, the pediatrician, that's a whole another hour for that one. But I mean, it's true, and it's a trust issue. It's always a trust issue, and it's a fact issue. And I hate to say it, but a lot of times the medical community speaks at a level that folks just don't understand. Herd immunity and blah, blah, blah. That doesn't make sense to the average person. So you really have to explain things in a way that people understand it, and understand that it's not scientific mumbo jumbo, that there's a lot of thought. For example, this whole, well, I took the shot and I got the flu. That's the one I hear all the time. And so we have to explain the time frame within which an immune response takes place, and this doesn't mean you got a bad batch. It just means it didn't kick in yet. So all those types of things. And so we flu season, we stay on the air because it's a talk, educate.
Well, thank you very much. That's a perfect way to end this panel, I think. And thank the panel for being on the front lines of all this at your various jobs. We're really lucky to have you all in this arena. Everybody, a hand for the panel. And so we have about 2 minutes left, so I'm going to hand it back to Dr. Ross to close us out. Thank you.
Thanks, Joe. Gee, this has been a wonderful program. I want to thank all of you. Here we have the local health authorities. We've got CDC, we've got the World Health Organization, we've got Securus. We have represented tonight all these different parties and partners. And we started tonight, mentioned PIVI. I mean, it includes the word partnership. And one of the things I took away, I've always known about public-private partnerships. But tonight, what really that says to me is the power of powerful partnerships. And what we have here in PIVI and this local to global country-wide connection is the set of partnerships that will really bring better health to the world. So I'm kind of leaving tonight with the sense that we have a future where together I think we can commit, a decade from now we should meet here again and say now every country has a routine flu vaccination program and has the capability to be prepared for the pandemic. I think we ought to have a goal. I want you to know we here at the task force are thrilled, privileged to be a partner in making this happen, the PIVI program. We're privileged to have the ability to have hosted the WHO group this week. Thank you for coming.
Fabulous place.
Well, glad it worked. I want to thank all of our folks who have make that possible. And there's a ton of food apparently, so we want you to eat. Those of you who are locals, don't be ashamed to pack it up and take it home. That's a practice here at the task force for our staff. That's one of the benefits of being on the staff here is you get fed a lot. But no, really, I think we're really enormously pleased that this event is kind of the beginning of this kind of routine event, and that we now have the ability to host and do these kinds of things. So go forth, do good, and I think we will win the day. And maybe on the side, Sandy Ford, I want to tell you my experience back in '77 was at the Hopkins Health Services Research Center, and we decided to go out and study medical practitioner knowledge of flu and vaccination. And it taught us exactly what you said, is that, in fact, those who know the most are primary care docs, no surprise, but those who know the least were surgeons. But yet, within the medical hierarchy, the surgeons carry the most power. And so to have the people perceived as being the biggest, most important docs saying the wrong message is a huge problem. And so I will offer, as closing remarks, my answer to your question about the PR campaign. I envisioned, as you were talking, the Sucks to Be You campaign. Let's imagine the video. So somebody, you're standing there waiting for the bus or the taxi or something, and the question about flu vaccination comes up, and the person says, well, why would I get that? And you'd say, wow, it sucks to be you. And you know, you couple that with the highlights of the tragic stories, but turn it on its head. It's like, wow, this unfortunate for you. You didn't get vaccinated. It sucks to be you, right? Anyway, obviously, I'm not in marketing for a good reason. But with that, thank you all for coming. It's been a wonderful program.